So thank you very much. Thank you, Oculus, Sven, Daniela, for for the invitation. It's a pleasure to be here. So welcome to Zurich, everyone. And the subject, I'll give more practical and show you some cases how I used to see the Pentagon before cross-linking and after cross-linking as well. So this is, maybe you've seen this before, we've presented many times, but keratoconus is not a rare disease. The last green numbers are from Saudi Arabia that we did a study in 2018. It was published, and we saw that's very prevalent in some areas, especially in Middle East. And then now, also thanks to OCULUS, with the support of OCULUS, we are trying to expand this globally to evaluate many keratoconus or children to see the prevalence of keratoconus in those areas. And we saw one of the reasons, of course, there is the place, the geographic location, but the technology also has improved. You can imagine before we didn't have these beautiful maps. 20 years ago, we had only keratography or the early study was just with the light reflex. And now we have all of these, and that's how we did this study in Saudi Arabia, collecting the Scheimpflug from Pentagon. Though we had between, I think, 500 cases, 9 cases in which me and Professor Brad Renderman disagree in the initial diagnosis of being keratoconus or not. This is one of them. And we were looking at all of the index that Pentagon had available, not only anterior surface, but also BAD-D, everything that you can imagine was used, so it was a completely subjective analysis. And that was another case that one said one thing, the other said the other thing. What do you think, Sven? Okay. Well, so that was the prevalence of keratoconus. And this is very important because now we can treat with cross-linking, and if we treat, we maintain the vision of the patient, and also on top of this, we bring these numbers to the public attention, and this brings more money, which brings more research, and at the last end improves to the vision of the patient. So it's very good in all senses. So we move back from this moment where the refraction or the slit lamp was done to identify very advanced forms sometimes of keratoconus. And then after came the topography. Stephen Kleiss is here, so he was a great part of this development. And then Scheimpflug as well, in which now not only the anterior surface, but then we could have, as you all know, all the 4 maps and much more of this. So Scheimpflug technology brought us a lot of new information, and on top of this, now we have we just heard about Ricardo. He did a lot of those studies about biomechanics, that we can also see how a cornea changes with pressure or induction of pressure, and how biomechanics it can changes between subjects. So this combination was a very nice combination from the geometry of the cornea with the Scheimpflug imaging, not only the anterior surface but the whole cornea, and also the intrinsic parameters of the cornea, let's say the biomechanical. So this combination is very nice, and we have those maps which are I use them a lot. So sometimes we spend some days here speaking about all those numbers, but when it comes to the patient, those maps are very good for exemplifying, especially those numbers, CBI, TBI with the color, so they easily understand. And this is the Ricardo subjects, but just summarizing, and he is the expert on this, but they basically compare normal with keratoconus, and as you see here, all the index, so the higher the lines are, it means it identifies good. So they all identify, all the index separate well if it's a normal cornea or a keratoconus cornea. You can see on the graphs. The big question that we want to answer was that, is it this cornea normal or slightly asymmetric, or is it an initial ectasia? So they came, Ricardo and Renato, with this study, and now they could see that the TBI was better than the CBI for this purpose. Correct me if I'm wrong, Ricardo. And that's their published specificity and sensibility. So this is a great advancement for us to understand, and also for the patient. And basically all of the Scheimpflug advantage came, maybe the big improvement that they came was because of the pachymetry map that for the first time could have acquired, and also the progression. So here differentiating keratoconus with the line normally going down there, as you know, normal corneas, and also Fuchs or edematous corneas where sometimes the line is completely flat. And then this was also incorporated to the Bellin-D, so this is just an introduction, and for those who do not understand, so the top images are the best fit sphere, so they are the normal cornea, so the same sphere as you see on the yellow, so it's an average of the whole cornea. But if we have an average, we cannot see very well where the keratoconus is. So then they came with the idea of adapting this best fit sphere and removing this central area. And now there is a new best fit sphere, which are on the two images on the middle. And the difference is below. So that's all now we have available. So there are a lot of information, and we could speak about many hours on this. But all of this effort is to basically identify normal patients, borderline or initially keratoconic, then keratoconus patients. The true keratoconus are easy, but these borderline are the main challenge. So this is very important for the screening. So if we see, as Ricardo said, some abnormality, it doesn't mean we will treat, but we have to screen this patient sometimes closer. And this is an example. So the patient had 12 years old and came with this progression. So you can see on the right image, it's a very clear progression, no doubt. And then we said, okay, let's see her sisters and her brothers. And here comes the brother with also 9 years old. And you can see the topography is very normal, but the CBI and the TBI, the CBI is very high and the TBI is also high. So this is a case where we have to follow, although the topography is completely normal. So with all this technology, we can identify those cases and follow up, instead of saying just base it from the topography. Okay, come back in 1 year. We can say let's come back in 3 months to be sure that's not progressing. So that's very, very helpful. And then coming back to the ABCD, so we exactly did what I told you. So follow up this patient closer. And then the big advantage of the ABCD display that we heard before is that we can group all the measurements in just one photo. So you don't need to open one by one. You just open all of these and see the last one. In this case, are the blue ones, and you can see there are similar, all of them. So in this case, these form first of keratoconus, and there is a debate what it is. There are many definitions. But in this case, it was stable. So what I'm going to show is what I personally see in the sequence, and then maybe you can share how you do as well. But I normally start looking the maps for diagnosing or also for progression with the 4 refractive maps. That's how I learn, and that's how I correlate. So correlating pachymetry with the anterior surface and elevation all at the same time. Then we have the refractive indexes in the middle. So I just have a look very quickly. It takes me 2 seconds to have a look. We know that they just account for the anterior surface of the cornea. And here it's everything white, so no abnormality. I also check this very quickly. And for the patient documentation, normally we take the ABCD method. So I just take if A1, B2, just for documentation purposes for the patient. And then at this point, I have already had my own assessment based on initially the 4 refractive maps, and then I see the Bellingham-Brosio display, and then these kinds of confirms what I thought or not. But I see this at the end. And on the cases we have questions, so the patient came back, and the second time there was a suspect topography, then of course I would compare the pre-topography and the actual topography. So that's my personal way of seeing all the Pentagon sequences, but of course there's no right or wrong, it's just my way to see it. And then sometimes our question stays on this photo actually. The patient came, we had a suspect topography, and we are not sure if it's progressing or not. So the question now, is this patient progressing? Then in this case was quite easy, but we can also confirm with the ABCD progression display, and you can again see all of them at one time. You can see very clear. Of course there is variation, but all of them are below the threshold of the green or the red lines. So now I'm going to show you some cases. So this is our first case. So the below right image is the differential map between the first, so top left, and the initial one between 2013 and 21. So a lot of time. And you see on the right below image there is a huge progression of 13 diopters. So at this case we don't need anything more. This is clear. We don't even need the differential, but just the numbers. It is a progression. And how do we see this at the ABCD? So we see a huge progression. So what would you imagine? So a big increase on the last measurement. So the pink color. So this was easy. We didn't need the ABCD, but it was easy to identify in both. So now a 9 years old patient with so biomechanics were altered in both eyes, and then again I think that was the case we just mentioned, that was completely stable on both eyes. Now this case, so that's the right eye, left image is the last consultation, and the right is differential. Who would say that this is progressive? So that's not progression. Why? Mm-hmm.
The shape so much, so that is the refractive influence of the shape. It's not the shape.
Mm-hmm. And now the left eye. Yeah, so those are the cases. I think most of us have some questions with more experience, like Paolo. Maybe he has, he can see something that the less experienced cannot see. So for me, those are the cases that the ABCD are very helpful, because we have some areas of flattening and we have some areas of steepening. So then we look to the ABCD and now, yeah, it looks stable. But on the first one, we see it progressive, the first curve, so the A here on the left, I don't have my notice here with the date of the patient, is not appearing to me. But it was on the left eye stable, the right eye more or less, and it was, I would not treat based on this exam, but on the A on top here, we can see there is a tendency of progression, as Paulo said. So this, for me, is still questionable. I would ask the patient to come again to confirm this or not. What do you think, Paulo or Ricardo Ferri? So on the left, on the right eye, on the left image, progressive. Yeah, I don't have the notes here. I took notes, but it's not appearing to me here. I don't know. So case number 4. This was another patient. So for me, a questionable progression as well. If we just look at this exam, I would say, okay, it's likely to be progressive, but if you take, it was around a year difference. Around a year difference.
If you use the tangential map, you will see it much more. Particularly when you have these tiny changes in the area of the cone, the tangential map will.
The more the cone is outside of the center,
Yes.
the less the excel is able. But here the cone we have here still a clash
Over
of
there.
over everything.
Yeah. Some comments, Steve?
I think, I mean, I've used, I've looked at the repeatability of the pentacam many times. I've looked at the repeatability of the pentacam many times, and it's really good as long as you have a cooperative patient and no red spots, So this repeatability is excellent, but notice, I mean, these powers are huge, and these are tiny deviations in those powers. I'd say that's a stable cornea in the absence of any other.
Yeah, exactly. That's why I thought as well, because the for me it was still very questionable because the keratometry is very high, and also if you take the same eye and you tilt a bit the eye, so the patient is looking a bit down, on the same day you can have this difference. So,
But you can have a point of difference because all the repeatability that we have are related to single points. So we know that, for example, the Kmax in this case, the repeatability will be probably 1.5, 1.6, even more, because it's 60 plus. But here you have a trend, so the whole cornea is going to plus. It's between 0.7 and +1, but it's a big area that is all going to the plus. So it's not, 0.7 plus, 0.4 minus, it's all 7. So I would say
yeah, but then that's the beauty, because we have different opinions on the same, and both of you are experts. And for me, it was also questionable: is this progressive or not? And then comes again the ABCD progression display, and then now it's clear, it's progressive. But we're just seeing 2 exams. So between 2000, the last 2, the blue and the red one, the other ones we didn't. So it's very helpful, especially on those cases. Then, well, we have a patient with, it was progressive. So now we will do the treatment, the cross-linking. So we have 2 principles here that you all know. First one is the stop progression, and then the improve vision. Maybe here there will be some novelties that Farhad Hafezi will speak tomorrow and the day after with the customized cross-linking, and then this can kind of change a bit. But those are the traditional pillars we had with the treatment. With cross-linking, we know that stabilize the cornea and sometimes even improve the vision. And now we can not only treat the normal corneas, but we can also treat, as the colleague said, very thin corneas with this sub 400 protocols and also other ones. So we are able to treat those corneas, and this is an example of a year follow-up of those corneas. So a central flattening, so the green area right below. So cross-linking works even on very thin corneas. but we also have to improve vision. Here I will not speak much about this because there is another subject, but we have many ways to do this. The point is, once we did the cross-linking, then we'll see the patient after cross-linking. So that's the initial point. The patient come back 6 months. If there is no change in the topography, it's very easy. So it's stable, everybody's happy, if the patient, especially if the patient has a contact lens. If not, we can think about what to do. If there is a flattening, well, there is a flattening, you can see this. We just have to remember the flattening sometimes is related with the haze. I will show you some cases. And if there is a failure, we have sometimes to repeat the procedure. The question is, sometimes, is the patient stable or is the patient not stable based on the Scheimpflug images? So here again some examples. So the right image is the differential map. So the first one is very clear. The keratoconus is progressing, no question. So repeat cross-linking in the case this patient had cross-linking. So the middle one, there is this green area in the middle, and now it's also clear it stopped progression and it still got flattened. So no question as well, the patient is stable, or more, even more than stable. But again here, this was one of the patients I also had doubt. Is this progressive or not progressive? And then we have to remember, as I said, about haze. Basically, most of the patients after cross-linking has a haze, a mild haze, but they have a haze. And we have to remember this. So here is an example, just 1 month after the surgery. So the right below image are the densitometry, and Pentacam is very, very good for this because we can follow up the patients with haze, especially for starting therapy with dexamethasone. We give and we can compare objectively. So it's very good to see those changes, and we saw those changes. So the first month post-op, and now you can see 8 months after the surgery, the same patient. So before they had this topography, some would say no, it's progressing, it's a month after. There are many factors, epithelium, all of this, but the haze is something we monitor, and then now it's much lower. So the haze and the evaluation in the first year especially is something that we have to think about. And that's again where the ABCD comes into the game, and that was one of the reasons it was conceived, and it helped us a lot to identify those patients after cross-linking. So here Michael mentioned on his presentations what he collected patients from us in Zurich and Hamburg from Professor Seitz, and what we sent him the data was after cross-linking, just repeat the examination, asking for the patient to remove on the same day, remove and coming back in the Pentacam, just to see how different it would be after cross-linking. And then we have the values that Ricardo and Michael are experts here. But basically what is now integrated in the version are those, as you saw before, those blue columns. So to finish, I will just present you 2 cases in which we used those, you can see the difference. So this is a patient 1 year and after, 1 year and a half after cross-linking. So here we have January this year, he came back, it's stable. And then 1 year after the cross-linking, we are able to see those blue. If it's less than 1 year, it doesn't appear. It has to be 1 year after. But then you see those blue lines. And if you look at the the letter C, the thinnest point, you see the yellow first line, and then you see after cross-linking a huge increase on the green one. And you might think that's a progression, but that's known to happen after cross-linking, and that's why the ABCD came and to follow those patients. that's probably because of the haze. But then you see the blue columns now 1 year after, and you see that is not reached until the area within the noise that we would expect. So here, this is a clear case of stable keratoconus after cross-linking, and here a last case showing how it would look like another patient 2 years after cross-linking. For me, was also questionable if the patient was stable or not. But then the ABCD helped us again and show that this was probably within the normal range. So of the patients after cross-linking. So as a final message, as we saw at the beginning, the keratoconus is not a rare disease, and one of the reasons we might have detected more prevalence of this disease nowadays is the technology that has higher sensitivities in detecting early forms of keratoconus. The progression display helps to detect corneal changes in a very systematically way and even more accurate. This was one of the papers that Belin showed. So it was a completely independent analysis of some groups from Asia, if I'm not wrong, that did this, and they saw that it could help. And those confidence intervals for cornea after cross-linking are now integrated in the generation of the software, allowing the analysis before and also after cross-linking. Thank you very much.
Other questions?
I have a general interest question. Probably this has been answered before, but in the USA FDA clinical trial, we saw exactly the same thing that Ricardo showed, that after 1 month, the cornea seems to steepen. Now that all you guys have OCT, is this epithelium or is this a true? It is. Thank you.
The mic.
Oh, sorry.
I think Leo Colros, who's sitting right behind you, he started looking to the last 100 crosslinks we did using Pentacam, and in retrospect, in how many cases did we suspect, based on Scheimpflug imaging after 6 months, a progression, and in how many cases do we have an OCT-based topography to see? And we will analyze these data, but it is our impression that we recross-linked quite a few cases back in the days, because we thought it was actually a progression, whereas it rather was epithelium remodeling.
Something interesting is that years ago we published a study where we measured the topography before of the cornea with cone, after removing the epithelium, making the topography and showing much more steep. After the cross-linking was immediately flatter. But before we see the effect of this, we have to wait months. And with the OCT epithelial maps, we understand why after.
Oh, yeah. There is a question about the sub 400 protocol and cross-linking thin corneas. And because this is not really in the scope of this symposium, I suggest we discuss it, for example, tomorrow at the wet lab or during the day, because that's an entirely different topic. I will be short. I shortened my presentation. It will be probably less than 10 minutes. But this way we can all enjoy our dinner. So what I wanted to look at with you is what Stephen, you have mentioned about when do you clinically see a patient again? We've seen all these questions around, is it progressive, yes or no? When do I clinically decide to go into treatment? And just to remind you that, as we've discussed before, many of us prefer to treat children and adolescents, which according to the definitions of the United Nations and UNICEF would be 8 to 19 years. We should treat immediately. There was a paper that came from my group that saw the natural progression in this age group of 88%. That was 10 years ago in a relatively low number of, I think, 70 70 subjects, but last year there was a large Australian study with more than 600 kids and adolescents confirming the range. So 8 to 9 out of 10 in this age range will get worse. So do not wait. I wouldn't wait. Regarding when to see a patient back, look at these two topographies. There is an increase of more than 4 diopters and a decrease in CDVA of 3 lines, 15 years old. For some reason, the teenager didn't get a cross-linking right away. How much time do you think has been in between these two measurements? So the doctor decided, come back, and this was me. This is maybe 10 years old, was around 2011-12, and I thought, come back in 12 weeks. That was 4 diopters in 12 weeks. And so I know I burned my finger. Whenever I have reluctant parents that don't want to cross-link, I tell them 4 weeks. I see you in 4 weeks. And if there is nothing, I see you in 8 weeks, and so on. In adults, we have to have the indication of a follow-up also for medical legal reasons in many countries, including Switzerland now, if you want to have healthcare reimbursement. As Emilio has shown, this of course is a very strong indicator of potential progression, but these are secondary factors you should think of when you plan the clinical follow-up. So you see a patient with a clear cone, 28 years old. When should the patient come back? One is certainly age, right? That's the second symbol. The older, the longer probably the follow-up, and you listen to the patient's history. The one on the left, that's trisomy 21, Down syndrome. That's the symbol for Down syndrome. If you have Down syndrome, the likelihood of progression, it's a collagen-related disease, is higher. So I would see them much earlier. If you are a chain smoker, you induce a lot of crosslinks via the glutaraldehyde that you pump into your blood while smoking. Think of the Marlboro cowboy. He's cross-linked. The skin is cross-linked. So we published 11 years ago, still with the aura, but highly significant, that a chain smokers have a much lesser incidence of keratoconus than the normal population. Finally, hypothyroidism, that came from a German group around Thanos, and Brett Randleman had a very interesting case report. We had a case report, and we had a paper showing that hypothyroidism is related to changes even during pregnancy. So hypothyroidism can make a keratoconus explode in the 4th and 5th decade. And Ahmed El-Masri, you had 2 case reports published on the topic, and you had another study published. I can't remember the exact consequence of the study, but you looked at the population, right, in hypothyroidism.
About 4.5% of the patients with keratoconus have abnormal thyroid gland dysfunction. 4.5. Yes, yes.
And this is why, do you recommend a T3, T4, TSH screening in every keratoconus patient? We do too. Every cone patient is sent to the GP and has thyroid levels checked. In hypothyroidism, you don't do LASIK, and this is a routine question we ask now also in our refractive surgery patients. Finally, estrogen-related changes, pregnancy, we all know about this. And 2 more unusual things you should keep in mind. The sign on the right is diabetes. We know that the glycolization end products in the metabolism creates additional crosslinks. So these patients should have a lesser prevalence for keratoconus, which has also been shown epidemiologically. And SERM, selective estrogen receptor modulators. So if you have endometriosis or cervical cancer, you get treatment for cancer that increases the tissue's sensitivity to estrogen. You can have a cone that explodes. We had a case that now was you published it with us, Emilio. It was the most downloaded in JCRS 2 years ago. And this was very interesting. 56-year-old lady with a cone. And at 56 years, you think, oh no, she will be stable. She came back with an exploding keratoconus. And we asked her what happened. She said, oh, I was diagnosed with cervical cancer, and I'm receiving this medication. And this is how we realized this has a heavy impact. In your follow-up, beware of this. We've heard this multiple times. So the steeper the cone, the higher the variability, even in the same machine. And of course, if you are in the same technology but on different devices between different doctors, you have the inter-machine variability that plays a major role. This one should be self-explaining, but still, I'm surprised how many colleagues do not tell their patients to stop wearing contact lenses before they get any measurement. So the warp pitch. And then we spoke about failure, when to crosslink based on what we have seen now in topography and tomography. But just to remind you, there is early and there is late failure. Early failure would be a few months after crosslinking. And so you see the patient clearly progresses 2, 3, 4 diopters and not too much haze. So if you see a failure at that moment, you should consider recrosslinking. Late failure happens when the turnover of the collagen has run its time. So if you look at age and you plot the effect of age on biomechanics, this is mainly Ahmed El-Sheikh's work, who showed that the older we get, the stiffer we get. So you have an increase in crosslinks over age. Probably one of the reasons why keratoconus stops someday. And if you see a patient that is progressive, let's say at the age of 27, and we perform CXL, we induce crosslinks, then this effect will wear off over time because our body renews. So after 6, 7, 8, we don't know the exact number of years, there won't be any CXL effect anymore, but what keeps the patient stable in this age range is probably age itself. If you do the same thing with a 12-year-old, well, you shouldn't be surprised to see reprogression at the age of 21 or 22, and out of clinical experience, most of you know that this can happen. On the other hand, you can have 40-year-olds, right, that can progress. Paolo and Ricardo, you published a large series on patients that were progressive over the age of 40, and you performed cross-linking. And Leo just published with us a few days ago progressive keratoconus over the age of 48. So just keep in mind, for the follow-up, the likelihood goes down. It is never zero. It's very unlikely to be progressive at 52, but we see them. If you have a large population of conus patients, you will see them. Ricardo?
Can I add one thing there, please? There is a paper.
Can you take the...
Just adding exactly, there is a paper in AJO that is coming from Moorfields, and they have a risk calculator online that is absolutely free. It's called Moorfields Keratoconus Calculator. You put Kmax, age, K1, and thickness, and it will tell you based on 8,700 eyes what is their percentage of them to progress.
Cool.
It's for free,
Cool.
online.
Yeah, please share the link with us if you can. Maybe you could even, and also tomorrow. I didn't know about this. I'm through. It's been a long day. I just wanted to remind you one thing. We talk about all these fancy tomographies, back surface, pachymetric maps. In the last 15 minutes, I went back into PubMed just to remind you that the man who brought it all to us is sitting here in row number 1, Stephen Kleiss. And without your fabulous idea of combining a personal computer with a Placido disk, we wouldn't be sitting here. So thank you, Stephen. This is it. Any comments on how many of you do T3, T4, TSH screening in keratoconus? The others, please consider. You will be surprised how many of them will tell you, "Oh, I don't have enough thyroid hormone. My doctor told me. I'm getting Eltroxin now." It's really quite interesting.
And you'll be surprised how many have relatives with thyroid pathologies.
Also, and Hashimoto and others. Yeah, it's highly interesting. And pregnancy makes a physiological hypothyroidism. That's also an interesting one. I think we're all ready to enjoy the evening and restart fresh tomorrow morning. Thank you.
Thank you.